Hello, guys. So we are back. We're going to go over chapters 23 and 24 because they're kind of similar. We're both talking about urinary tract infections and urinary incontinence. So we're going to get started on urinary tract infections. Maybe if I can advance the slide, maybe not. Oh, and it moves. So that's interesting. Okay. So let's talk about urinary tract infections. Pretty common, you think, Terry?
Very common. See this daily in most cases as well.
Alrighty. So you guys can read through that. We know kind of the reason why women are more susceptible to urinary tract infections from their short urethra, right?
Exactly.
And that migration, of course, of that bacteria that can potentially go up in there. E. coli, we all know that the majority of bacteria we find with UTIs is E. coli, of course, and we know the rationale behind that as well. Okay.
Exactly.
So it makes sense. So there's asymptomatic bacteria and cystitis. Anything we need to add here, Terry?
Well, a lot of women come in for their general physical exam once a year, and they think that we should check their urine. And it's not really recommended that you do that to find out any problems unless they are symptomatic of something, whether it's frequency, dysuria, nocturia. So there's reasons for checking a UA, but as just one of those general routine urinalysis, it's not necessary.
Perfect. What about pyelonephritis? This is a good one. Bacteria kind of starts traveling up the urethra to the ureters and goes to the kidneys. I see this, I think, more frequently in pregnant people. That's a big risk factor, right?
Yes, absolutely. Okay. And certainly that pregnant person who you feel like she does have pyelo, she needs to be hospitalized.
Oh, 100%. Yes. IV antibiotics in the works, right? Absolutely. And we're talking about fever, chills. It says it up there, fever, chills, back pain, costovertebral, that angle tenderness, you know,
CVA
how we
tenderness, and that is heightened whenever you see pyelo.
Very classic.
Yes,
kind
very
of thing,
classic.
Right? Yeah, absolutely. So uncomplicated. Non-recurrent bacterial cystitis treated based on patient's history alone, no laboratory test required. What do you think about all this?
Well, I'm usually checking a UA. I feel better if I'm going to give antibiotics to someone. I want to see them. Many times they just want to drop off a urine. Well, when they do that, I don't know, are they febrile? Do they have CVA tenderness? What are their symptoms? And they will call in, I think I have UTI. I'd like to just drop off a urine. It's like, I'd really like to see you before I do. So if that's a possibility, see your client, because seeing them and seeing a clean catch urine, where in women, that's a very difficult task.
Yeah, I agree, honestly. All right. And of course, culture and sensitivities, right?
So
what's your thoughts on that?
With a young woman, and this is the first time UTI, I don't always get a culture and sensitivity. I usually choose based on her specimen results as well as her physical results, treating with short course of antibiotics. But if I have an older lady, I don't really have any parameters, say women over 60, and she's had a couple of UTIs maybe recently, I'm going to do a culture. That's important because you want, particularly if you have treated someone with antibiotics, 2 weeks later, she's in your office again with the same symptoms. I don't think that's when you're going to get a urine culture on her.
Perfect. So dipstick is usually positive for nitrites, leukocyte esterase, and red blood cells. You kind of agree with that? Yeah. Okay, cool. Whereas pyelo, you're going to see white blood cells, right? Of course, they're going to have more of a real true infection kind of thing right there.
Yeah. And you have to be careful with red blood cells in women because they may forget to tell you that they're on their periods.
Yes, it's so true. That is a good point.
Yeah.
And sometimes because they don't do specimens, would you agree with that? Like they
Yes.
should, like spread their labia like
Yeah.
they should to make sure it's truly that still that blood can interfere there too.
And
as
if I
well.
have a lady that comes in and thinks she has a UTI, she's on her period, I'm probably going to do an in and out cath on her. So we have a little female cath kits that we can do in a cat. And so that way it takes out that period that can confuse your results.
That's a great point. That's a good pearl, by the way. So that's awesome. So it does talk about urine culture with sensitivity test guides treatment. Of course, you know, we still have to cover the patient because it still takes some time for that to come back if you decide to send a culture. So that's why you're going ahead and giving them
our
those
office
antibiotics.
will prep the culture, and they will do an initial after 24 hours. So if it's positive, they send it on to somewhere like LabCorp so that we can get that urine culture and sensitivity.
And then you just call the patient back if that antibiotic doesn't cover.
Once we get that and say, I have treated them with, say, macrobid and it's resistant to macrobid. Once I get the culture back, then I'll call her and I was like, you need to stop that one. We need to treat you effectively with what we got on our culture.
Perfect. Yep. All right. So here's some differentials. Anything else that you think that's not covered here as far as differentials that you can think of? I think it kind of covers a lot.
Covers a lot. I would just add vaginitis onto that as well, because many times when they come in and they think that they have a UTI. Well, what are your symptoms? Well, I have a discharge. Well, you're not going to have a vaginal discharge if you have a UTI. So I'll check both. I'll do a clean cut urine urinalysis, and then I may do a vaginal swab, and the urinalysis is completely normal, but I may have yeast or BV on the vaginal swab.
Wow.
So that's one thing personally I would include in that. Perfect. Well, it includes the sexually transmitted infection. So that's one of those that sometimes the symptoms cross over.
That's what I was about to say. You can kind of see that cross.
Yeah.
Yeah.
You may not.
100%.
Well, if you have a woman with dysuria, well, does it burn while you have blooding stream, or is it after, and is it more external? Well, I can't tell. So if you have dysuria, there's possibility that you could have yeast infection that's causing that. So
it's a lot of differentials to make sure that you cover your basis with that. I agree. So here's our antibiotics. We kind of talked about that just a little bit, and it says like use cheapest, narrowest spectrum antibiotic. And you've kind of already kind of hit with that and what you thought we could do, right? 3-day regimens for sure. I've seen 3 to 5 just in case.
Yeah.
I've never seen a provider really go 7 days ever.
They do. I've seen it happen.
It's a complicated one.
No, particularly in primary. Primary tends to overtreat.
That's good to know.
They do. And
That's good to know.
And then they come into me and it's like, wow, they gave you some of them 10 days.
I know.
So I typically, if their symptoms have just started, they're afebrile, we've got a positive on the urinalysis, I'm usually doing a 3-day treatment. Less antibiotics, the better.
Right. Yeah. And whenever I was doing clinicals, the provider I worked with would always do 3 to 5. He was like, don't ever tell me 5 to 7, you know.
Well, and if you've got somebody who's, how long have your symptoms been going on? Well, maybe 2-3 weeks. I may give them 5 at that point.
That's right. Yeah. Good to know. See, everybody treats differently. So that's kind of good to see that perspective. I love that. So of course it says it can be extremely painful. Absolutely. Of course, you know, with these patients, you got to listen to what they have to say. And here's the pyelo again. We're saying we're sending these patients to the hospital, essentially.
The pregnant lady.
The pregnant lady,
but
for sure.
If you have somebody who is not pregnant, she maybe have a low-grade fever, you've got a positive urinalysis, you can treat her safely in the office. But I would see her back the next day or the next 2 days to make sure that she is responding to treatment.
So you're following them closely and making them come back if they spike a fever or something out of the ordinary, right?
Exactly. I might even, I don't, it doesn't talk about what test that you do, but I oftentimes will go ahead and do a CBC because I want to see what her white count is.
Yeah, you're trending that white count for sure, making sure you're going in the right direction, right?
Yes.
Yep, and it's not getting worse. Perfect. So it's just treat 5 to 7 days or fluoroquinolone.
And the fluoroquinolones, that's not my first choice, which is uncomplicated cystitis. But when you think and highly suspect pyelonephritis, certainly that's what you're going to go for. You want to get that. I've even given a Rostefan as well.
Shot, IM shot. Yeah. Good. Yeah, I could see that being like a real quick.
Yeah,
like put that in there. So
because when they're sick, and this day and time with COVID, you don't, unless they absolutely need to be in the hospital, you don't want to send them. Yeah, I mean, you have to think about what's trending at this point in time.
Yeah, but the pregnant lady for sure.
Oh, absolutely, pregnant lady.
Tons of those in the hospital, and that's why every time I see Pilo, I think of the pregnant lady because it's such a big risk factor for sure. Education. I think we all kind of understand education for UTI. Is there anything else that you can think of? What about the cranberry juice? What's your thoughts about?
Cranberry juice is okay, but this is what I tell most of my patients, because if you say, are you drinking liquids? Or are you drinking fluids? Oh yeah. What are you drinking? And when they're saying tea, Mountain Dew, Sun-Dried, coffee, they need water. And I can't reiterate, you got to drink and get this flushed out. So I tell them 8 glasses of water every day while you're taking this medication. If you want to prevent further UTIs, include water in your daily regimen.
Perfect. I like that.
Water. People, healthy people tend to drink water, but we've got a lot of unhealthy people.
Right. Exactly.
And they don't.
Exactly. I agree with that. And of course, we always give them recommendations like this says, contact your clinician or provider of assistance persist after that 48 hours of antibiotic treatment.
Absolutely.
And we all kind of know that because maybe they just,
if you're getting worse. And a lot of times what you think they should know, they may not think like you. Yeah. And you have to say, if you develop a fever, if your symptoms worsen, please let me know.
Right. All right, prevention. And this is kind of key factor, right? You have to have that conversation with your patients, of course. I know a lot of people even say like jacuzzi tubs. I've even heard that. Like,
yeah, I mean, that's that. I think about that, but I think it's not been documented that that's a real risk, but certainly it can be.
Bubble baths.
Yeah.
Yep. I know that's one of the things we would always talk about the bubble baths. Yeah. Like, are you taking bubble baths? Like, you have old grandma that likes her bubble baths, sitting in the tub. I know my mom takes baths every single night. Yeah. And I'm kind of curious how she doesn't get like,
well, and a lot of times that generation, that's what they do is in the bathtub. But
you have to ask those questions, right? You do, to figure out what's going on.
You do. The recurrent UTIs, 3 or more, and oftentimes this is what you have to be careful with people that you follow annually. They'll go, oh, I've had some urinary tract infections. Well, how many times have you been treated this past year? Because they may go to urgent care on the weekends. Or they may call a provider after hours because they don't want to come into the office. And so you have to check. And so what I run into is primary care might be treating them, or they're going to the urgent care and they may go to different urgent cares. But if they've had 3 or more UTIs within a year's time, I'm referring them to urology for other workup because I want to find out what's going on with them. Is it just because of their sexual activity, or is it something underlying?
Yeah, that's great. And the antibiotic prophylaxis, so whenever people have usually are prone to UTIs after sex.
Yeah.
I've seen that a lot in primary care during my clinical
And I
time,
have
too.
treated that way as well. So I've got several women, when they come in annually, I'm giving them, their dose they can use prophylactically after intercourse.
Okay, awesome.
I also encourage them to get up and urinate after intercourse and drink a lot of water as well, just so that prevents that.
Right, there it is. Evidence does not support cranberry products, but I'm telling you, there's those women out
use
there
them.
that think that that's just the go-to. What's your take on AZO standard? A lot of women always
They will
go
try
do
to
that.
treat
Yep.
it, and it's going to skew your dipstick.
Yep.
It's going to come up if they've been using azo for say 2-3 days, well, even one dose, it's going to show positive nitrites on your dip. So you can't always go by that. That's why we do a spin out urinalysis when you're in the office. I don't just rely on that dipstick. So it skews the dip, but if they need this other than irritation of the bladder, if there's true infection, oftentimes these azos are only going to cover up the discomfort. It's not going to take care of it because it's not an antibiotic.
See, you've taught me something there. So
Yeah.
that's really neat evidence there.
One of the things that I have read in the past about cranberry products, yeah, it really is. It does help with the environment of the bladder to prevent UTIs. But I've also read, we live in the kidney stone belt in the United States, and high cranberry, taking a daily cranberry can put people at risk for increased kidney stone formation.
Wow.
I know. So you have to kind of at least share with them that information that you know.
Yeah, see?
So they think they can take cranberry pills and drink their sun drops in their tea. And
yeah, education I think is so important for patients who don't really understand that.
right.
So there's adolescence. I think we can kind of agree with what it has there. Postmenopausal women.
And suspect if you've got a teen that comes in and you're treating her for a UTI, that's another question you need. Are you sexually active? And say that in front without the parents being there, because oftentimes that's your signal.
Oh, wow.
That they can be. It's not always, but that's your signal that they can be sexually active at that point in time, which leads you to other things to consider.
Other conversations there for sure. Okay. All right. There's your pregnant women. We know about pregnant women and how at risk they are.
So in our office, they are checking their urines very, very frequently, and many times that's when they come in for asymptomatic UTIs. So that's very important while they're pregnant.
All right, and you can see why pregnant women are hospitalized normally for pilo. Like it just says how they're at risk for preterm labor, sepsis, acute respiratory failure, and even death.
Yeah.
So we're dealing with 2 lives at that point. So
Exactly.
we have to keep that in mind as well. And here's some culture information to kind of tell you what to look for with different patients that may visit you in the office, and what that looks like, and how we have to take special consideration for.
And let me tell you that healthcare workers and teachers are probably the most prone, because we can't leave our job
Lord.
to go to the bathroom.
Yeah, how many
You'll
times?
hear that from teachers. I can't drink water because
Yes.
I don't have anybody to cover my class to go to the bathroom.
Yep, and that is so true. And even when I teach right now, I'm like, don't drink enough water because I'm afraid I'd go to the bathroom. And how many times have you worked a 12-hour shift as a nurse? You all have been there, I assure you.
Let me go take care of this. Let me see one more patient. Let me do this,
And
because I don't have time.
And you haven't peed all day, right? Y'all can vouch for that. I know it. Or ate for that matter. All right, so let's move on to urinary incontinence. So let me share this one. This is kind of moving rather quickly. These are kind of simple. You all should kind of know some of this stuff, so it should be kind of familiar, which is great. I'm going to move our little picture over to the side. All right. Complaint of any involuntary leakage. I know you deal with this, right?
Daily.
Okay.
Daily. particularly in the older woman, particularly after women have had children, pregnancies, the anatomy changes after a pregnancy, it changes at postmenopausal. And so this is commonly seen throughout the lives of women.
So one of the lower urinary tract symptoms, and is among the more general classification of pelvic floor disorder.
Absolutely.
And we've had conversations,
Yes.
surrounding what that looks like and what could happen down below, especially after women have had babies. We talked
After
about
women
that.
have had babies, and many times incontinence, so there's several types of incontinence, stress incontinence, urge incontinence, and even mixed incontinence. Then so women, the younger woman who has had a child after a pregnancy, she may experience leakage with coughing, sneezing, laughing, movement. She can't jump on the trampoline with her kids. These are all symptoms of stress incontinence. It's just like I explain this to my patients. It's like you have a little water balloon and you're putting pressure on that. And so the muscles that control the urethra are being affected during that time. So you'll see this type of incontinence in the younger woman. Pelvic floor is now one of our first line, pelvic floor therapy is now one of our first line of treatment before we send our patients to consider surgery. Surgery is widely done, in the most complicated cases, they're using mesh. But for the majority of the women who they're treating for stress incontinence, they're using transvaginal tape. But before we ever get to that point in our lives, we're gonna look at pelvic floor therapy.
Awesome. And we're going to talk about that because I think that's coming up. If you guys haven't ever seen it, it's pretty cool. So we're going to talk about it. So we do know that this occurs in women of all ages, right? I mean, essentially, and it increases with age, of course.
Maybe one thought or a differential diagnosis that would be with a young woman who's never had children that has leakage or bedwetting. One of the things I'm going to think about is interstitial cystitis, and I know we're going to be talking about that in a later time, but that might be a reason for that really young woman who's never had children.
See, that's good to know too. So here's the anatomy. I think we all kind of understand the anatomy that kind of coincides with this. It talks about what can essentially go wrong, with our anatomy that would cause this leakage. And you guys can read that. What about factors? What's some risk factors? And of course, genetic, fluid intake. Y'all can read all that: diabetes, constipation, smoking.
Oh, yeah.
All that stuff, aging. That's on there as well. But what does this patient look like essentially? Of course, symptoms can vary, and that's what Terry has just explained. It can be different, and no matter what age that you are. Duration, frequency, severity, what triggers it. She talked about it. We talked about in the past, even like the person going in a door and unlocking a door may even trigger you to want to empty your bladder.
Exactly. That kind of goes along with the urge incontinence, which is a different set of muscles of the pelvis. But regardless of what type of incontinence they may experience, caffeine, I get into, what do you drink? What do you drink most of? Oh, I drink some water, because that's what they now want to hear. Yes. But caffeine, that's one of the lifestyles that they can modify, and weight loss. Those are two things that they can modify to help with improving their incontinence.
Do you think a lot of people understand that caffeine is essentially a diuretic? I don't either. I kind of find that interesting that patients, like we said before, you almost have to teach them and kind of help them through understanding what stuff like that means,
And, before a patient when she's talking to me, and I see this a lot because I see the older woman many times, and before they don't want another pill. So it's like, okay, well, this is things that you can do without us even going there. That would require you to come into the office or require you to take a pill, because you can cut out some caffeine, you can work on your weight, you can include exercise. So just a healthier lifestyle can make a difference even in your bladder health.
Totally. I think that's so important. And then it says 50% of women with urinary incontinence don't want to report it because, they're very embarrassed, right? And so they don't know what that conversation is going to look like and if they even want to admit it to their provider. So I find that kind of interesting as well. So here we go. Your assessment with the patient and what that looks like. Would you add anything to that? I mean, as far as I know, that's hard to read. There's an international consultation on incontinence questionnaire. Do y'all give out questionnaires in the office? Unless
There
it
is a
wants it.
questionnaire whenever we're trying to diagnose IC that we use. There is a questionnaire that oftentimes it's just easier for me to go through with them, particularly the older lady and her amount of incontinence that I use. And correct me if I'm wrong, Michelle, there is when women feel like they lose their ability, they're a young woman, they lose the ability to either hold their urine, or they feel like that there is a lot of hesitancy that they can't empty their urine. We need to think about other neurological things.
Yeah.
Like MS as one of those, because it can affect the bladder and how that's emptied.
The nerves, all that lower stuff.
Yeah.
Absolutely, 100%. So here's a physical exam and diagnostic testing. There's a 3-day voiding diary, which is the least invasive. You can read all that. Is there anything that you think that
we
you
do
would have added?
urodynamics, which is the cystometrogram.
Okay.
We do urodynamics in our office. When I'm looking at, do we need to refer this patient for surgery? And those gynecologists who do perform the transvaginal tape or do the TBTO, they want these tests before they ever do the surgery to make sure they're a good candidate for these types of surgery. Most primary care offices don't do that, and they're expensive. So we have to make sure that the insurance covers these testing, but it involves some catheters, and it basically lets us know which set of muscles that this is affecting.
That makes sense. And then you can refer out.
Yeah, mostly, I mean, because we do gynecology and some treatment with incontinence, but certainly in the private sector who are doing primary care, you're gonna probably refer to the urologist or urogynecology.
Right. 100%. Makes sense. Awesome. So here's some differentials. I think they put that on table 24-1 in your book. And this is what Terry was just saying, treatment may require, collaborating with other people, because you are going to have to potentially refer this out, of course, especially, depending on what's going on and what they're going to need.
Well, a lot of times we get referrals out from primary care because they want to start with us first, see what we can do before we do refer them to the urologist.
Yeah, and that makes a lot of sense, right? Okay, prevention, and this, you've already hit this, which is so unique to me. Is there a risk factor for obesity? Can they lose weight? They can fix that.
Yeah.
Is there some sort of history of diabetes? Are they drinking that caffeine? What are they drinking? Have we asked those questions?
Well, and even if they drink mostly fruit juices, that is very acidic to the bladder and can irritate without it being cystitis, and they're not going to be able to hold their urine as long.
Yeah, see,
it's irritating.
Yeah, so. Good point. Right. Avoiding patterns in pelvic floor health. I know we always, kind of talk about Kegel exercises, and we've talked about those. You wouldn't believe the people that don't even understand how to perform an appropriate Kegel exercise. For sure. And what does that look like? And that's also over there, how to perform those skills. And I think that's important as well to teach your patient. Non-pharmacological treatments, and we've kind of talked about this. You can read through those. Would you agree? That's probably,
Absolutely.
yep, nothing that we could add there.
I think
probably.
both hospitals, it mentions bladder training, pelvic muscle exercises. Now, certainly there's some rudimentary, you can do those, you can tell a patient, but when it gets extensive enough that they're going to share that with you, you can consider referring to. Both hospitals in this area have pelvic floor therapy to work with a physical therapist. So that's become more and more accepted, and they want to do something without having to take medication.
Yeah,
so that's an
course,
active way that they can do that.
I actually got to see the pelvic floor. My preceptor actually does it at the office where I did my clinicals, and it's so unique. And I've, I was labor delivery whenever I first got out of nursing school. I've taught Kegel exercises, taught people how to do them, but to actually see how that works. You don't really know that you're doing it right till you see that movement up on the screen, that you're actually contracting the muscles that you're supposed to be.
Exactly.
And that
helps them to identify which muscles to control as well. Now, not only with the pelvic floor in the hospitals that we can refer to that works with the actual physical therapist, but we have some other techniques in our gynecology office that uses intravaginal devices that still does that stimulator. We have a machine that we do. So some women are really comfortable with us, and they'll come in and we'll do some pelvic floor. I've come in contact with something that can be done in the privacy of their own home, where they buy, we work with this company, but a little vaginal probe that can be attached to, somehow on the web.
Yeah, right. It has a computer chip, probably, that records.
And somebody, just like what they do with pacemakers, and they're working with a urogynecologist that gives them feedback. And so with this new system, they can they have to do it a couple of times a day in the privacy of their own home, and it's basically doing the same thing as retraining the bladder.
Yeah, I think it's so unique that that's out there. I think really
it's
cool.
Great that
I
it's
do
out
too.
there.
I do too.
Because mostly women, we live long enough, we're going to end up with having some
100%, 100%. Yeah, 100%. So pharmacological stuff. And I know we've all kind of seen these medications. There's for the urge type, we talked about the different types, the stress, and of course, postmenopausal women. Is there anything that you would add?
Well, I have to be careful when I'm prescribing this. So most of those, I'm going to say most of those agents are generic and widely available and can be easily taken. I never prescribe this for somebody who deals with glaucoma or gastroparesis, because that's a no-no on that one. That's contraindicated. But for those who do not have that or would like to try something, you explain to them that if the most common side effects are dry eyes, dry mouth, constipation. And if they are dealing with those issues anyway, say with Sjogren's or any of their medications that cause that as side effects, you probably want to be very careful about prescribing those. The other that we use is the Merbegron, I believe is Merbetric, and that works on a different receptor site. So we are actually getting that paid for more and more by insurances, and the cost is not astronomical. So I think even the state Blue Cross that a lot of the teachers have will pay for this at maybe $30 a month, that they can use that without having the side effects. And even women who have glaucoma, they can use Merbetric, and that works wonderful to help them with the urge incontinence.
That's awesome. Yeah, that's awesome. So stress, urinary incontinence. I see duloxetine there, and and pseudoephedrine and ephedrine.
Yes, I really don't encourage that. And so many times they're all already on duloxetine, but if they're not, and you mentioned that you want to put them on an antidepressant,
That's what I was
they
sitting here
don't,
thinking.
they don't want to even
Yeah,
go there. But so most of the time with the stress, it's they may be more open to the pelvic floor.
Yeah. Yeah,
As
see,
a-
that's
yeah.
great as an alternative.
As an
Yeah,
alternative, yeah.
non-pharmacological is probably going to go a lot further, probably with patients who don't want to add on more
Exactly.
medications, of course.
Oh, and one thing on the anticholinergics, there has been new information that there's more risk for dementia or Alzheimer's when you're using those on the 70 and older women. Yeah, so that's the women that we want to treat.
I know.
And
So what? Yeah.
So
you're
I don't want to be
risk versus
responsible for
benefit.
that. So
No.
I'm first saying if we can't do anything else, try the Myrbetriq. Now you do have to be careful with the Myrbetriq if they've had kidney disease.
Okay.
You have to be cautious about that. But yeah, it's a double-edged sword no matter way you look at that with
Yeah, you have to take
medications.
everything into consideration, I think, before you go there. Yeah, absolutely. Surgical treatment. Here we go. So there's some for urge and some for stress.
Mhm.
So now we talked about the sling that supports the urethra.
Right.
I
Yeah.
know that's kind of more common.
It is common, and this is very different than the mesh that they hear about. They call it, oh gosh, is this the mesh that they're having to take out because they're having complications with it? And it's not that the transvaginal tape can't erode through, but they used it for so long that's not that people are tolerating that very well. So that's going to usually be your urogynecologist or even the urologist. That some urologists will do that, and some gynecologists will do that. With the urge, the sacral nerve stimulator, usually a urologist is going to do that, or even the Botox injections. That's sometimes a last ditch resort over surgery.
Okay. Yeah. All right. So complementary and alternative therapies, do you ever see much with these as far as?
The pelvic floor.
Yes.
Yeah, the biofeedback.
Yeah.
And we do a pelvic floor, it's umbrella disc pelvic floor, but it's something called pretibial nerve stimulation. We found that that's very helpful for the woman who deals with urinary frequency. She's having to go to the bathroom to empty every hour or every hour and a half. She can't get a good night's sleep, and because she's getting up 3 or 4 times at night. We do this pretibial nerve stimulation, which is a form of acupuncture. So there's real evidence that that's helpful. And then, this is something that primary care can encourage is yoga, Pilates, and Tai Chi, and basically is strengthening the core.
Yeah.
And that really
would help down
yes,
below, right?
Absolutely.
See, that's so cool. Absolutely.
So
you wouldn't think.
if the lifestyle changes can be done, even simple things, that's worth it.
Love it. When to refer. Here we go. Of course, in your situation, like you said, you get people that are referred to you and then you refer. So it's definitely a collaborative effort on all ends, depending on what's going on.
So I had a lady who's 72. She's had several back and neck surgeries. The most recent was August of 21, where she had surgery of her neck and upper spine. And she used to have just some mild incontinence. Now she has no control. So, she thought it's because her bladder was falling as a cystocele, but that wasn't the reason why she's leaking. And I tried her on Myrbetriq, but she saw no evidence. We also, she was drinking nothing but caffeinated drinks. So her husband was there to support her, and he's going to see that so she said, he won't let me have any hardly at all, that much in a glass. So she did make those lifestyle changes, and she could see maybe a little bit of improvement on not having to get up as often at night. But because I could not help her those ways, I went ahead and sent her to the urologist for further testing because I couldn't make much of a difference. So I worked with her for about 5 weeks.
That was my
Yeah,
next question.
worked
So
with
how
her.
long did you trial the medication
So
for?
The Myrbetriq company claims that by just a few days you see improvement on that particular medicine, but I was giving her benefit of the doubt. I had some samples, I gave it to her, and I wanted her to see if there was improvement after 3 to 4 weeks. So I saw her back in 4 weeks, and that was enough time for her to modify her diet. But she didn't see improvement with the medication and the modified diet. So at this point, I thought, this is all I can do.
Right.
Let's go ahead and make that appointment for the urology consult.
Awesome. So there's stem cell therapy, growing knowledge about physiological and mechanical factors. You said you don't see much of that really. So that's a little kind of out
there.
Yeah, there.
We'll see.
Yeah. Maybe it'll come up.
Yeah.
Who knows? Components to consider always. We kind of talked about education throughout kind of our talk today for sure. How do we diagnose the type? We got to talk to the patient about what that looks like, what, exactly what Terry was saying, what treatments options are available and what are they willing to do, right?
Exactly.
What are they willing to do? And they've got to be, first of all, accepted of it and to say that they do have it, like we said. And then what treatments would they be willing to kind of?
I'm a little biased, of course, but one thing I can tell you about patients' response to nurse practitioners.
There we go.
We are well accepted, but you've got to have that ability for them to open up. So, that trust, that bond that you get with your patients, and they've got to be able to believe you. So after working with them, number one, make them feel so comfortable that they're going to share their history with you. And then once you start working with them, see them back and see them. That's another contact that you might have with them, as well as, excuse me, as well as you are forming that bond and that trust with them, and they will end up liking you, trusting you, and wanting to see you because they're going to listen to what you're having to say. They're going to actually do these things that you're asking them, and they're going to come back saying, "You helped me."
Yay, and that's the bottom line.
I think sometimes I'm not dogging PA, but I think sometimes with the PA, they're not giving them the time. It's hard in our world because we are expected to see as many as a physician or as many, but
and they put a time frame.
They put you in you're working against the schedule,
and the clock.
But one thing I hear in my office is you take time to listen to me, because if I don't listen to them, how am I going to know what's affecting them in their lives and what's bothering them? So I don't know how to help.
I couldn't agree more. And I love that.
I love nurse practitioners.
Yay, of course, yay. So we've kind of already talked about, of course, age and the older population being a huge risk factor, obesity, so we have to take into consideration BMI, weight changes, variety, race, adolescence, and it says children and even adolescents, could be at risk as well. Which could lead to psychiatric issues, which makes sense. Pregnancy, we all kind of know the pregnancy thing, with that baby and increased pressure on that bladder that makes a lot of sense to me, of course. Anything you want to add there? We'll keep going. There's older women. There's the bladder training medications as options. Women with disabilities, Terry kind of told you about the patient that she had with the neck surgery and what kind of symptoms she had after that surgery and how that could happen. Mm-hmm. There's culture and internet resources are available. Mm-hmm. Sometimes I worry about internet access. I tell my mom, don't get on the internet. Don't Google that.
Exactly. And they do. And then you spend your time trying to undo what they've already diagnosed themselves as.
Absolutely. So this has been great lectures on urinary. We'll be back with the next two, menstrual pain and abnormal uterine bleeding. So we'll see you soon. Thank you for listening.